probably since I started working as a physical therapist with individuals after mastectomy, hysterectomy, cesarean delivery. I really wanted to understand how rehab protocols were developed, like rehab surgical protocols. How did they come about? I'd worked with patients after knee replacement within the first few hours while they were still in the hospital recovering before they went home. And I've worked with individuals after shoulder replacement within the first week after their major surgery. And I followed a protocol in an outpatient setting. I always wanted to understand, well, how were those protocols actually developed? Were we just kind of robotic therapists that were just following this thing that was created before us? We had no say in the modification or the development of it down the line. I really wanted to understand the upstream effect of working with a surgeon on a protocol for a patient population to enhance their recovery after that major surgery. And so you cannot imagine how excited I am to be joined by Dr. Dan Vapne. He's a residency trained physical therapist and board certified orthopedic clinical specialist. He's renowned for his proficiency in addressing a spectrum of concerns, including low back pain, neck pain, temporomandibular joint dysfunction, headaches, migraines, post surgical rehabilitation. He excels in the treatment of children with conditions such as torticollis and developmental delays. Following his residency training, Dr. Vapne served as a clinic director for a large hospital outpatient private practice, leading a multidisciplinary team to achieve some of the best patient outcomes in the country. He currently serves as the director of clinical operations and growth at Advantage Physical Therapy and is an adjunct faculty member at Touro University. His research endeavors center on leveraging technology to enhance clinical outcomes and improving provider payer relationships to foster sustainable care models. Thank you so much, Dr. Vapne, for joining me.
It's a pleasure.
Dan, we've talked probably several times about this. I've been so just in love with your background, and you shared a story actually about your own personal experience about seeing your wife recover after birth. Will you just share a little bit about your background so that people can get more of a global sense of who you are and why you're passionate about early rehabilitation after a major event?
Yeah, so my wife and I have three kids, and our first one was during COVID, so it was a COVID baby. So the hospital experience was a little bit different than second and third, as COVID was uh, winding down. So and uh, we had an experience in like three different hospital systems. All three were completely different, and how they treated us were different. And I was just like, how is it that we can have three vaginal deliveries and luckily there was no complications, and that experience and the education provided by the nursing staff, how they triage us in each step be completely different. And It was very interesting to see how on the walls of one of the hospitals they said, "Hey, we have an early mobility program," but no one really got my wife up and going. We were basically sequestered in our room, and she just went to the bathroom there and never really left the room during her recovery as a whole. And there was no complications besides for the bleeding afterwards, but like no education done there. A lot of education on the feeding, but that was interesting how three different specialists had different education on that whole experience there. So I got really curious on who creates these protocols, who implements them, and how they're executed. Because at the end of the day, they're not executed, it doesn't mean anything. So the research can be biased there on all the outcomes if each clinician carries them out very differently, and that opens up a whole new can of worms. Linked up with a general surgeon that lives close by, and he's very passionate about procedures, and what can we do to limit complications? What can we do to guide that patient from uh, even that pre-arrival process all the way through from the like the education they receive before coming in to their follow-up with him to seeing the physical therapist, maybe a dietitian, and then the surgery, and then what happens after that. So we're trying to streamline that entire process, but also make it so that the patient experience is excellent. They know why they need it or why they might not need the procedure. What can we do conservatively in order to not need it in the future? What are the possible complications? The more educated the patient is about the procedures and what can happen, the better I think the entire experience will be. And meeting those expectations is huge to the the outcome.
I totally agree with you. This past summer, I mean, not even just a year ago, I was working with patients after shoulder replacement surgery, and they came in with their protocols. They were incredibly informed about their surgery, about the therapy that they had beforehand, what they were going to be doing week one. Like they had protocols in hand, knew exactly what their treatment, their recovery experience was going to be like. And Dr. Vapne, I mean, I think about the patients I saw after mastectomy who just didn't have a clue, didn't realize that they were gonna be so limited with just even, like, making their bed, getting dressed. It was such a ironic experience to be working with someone really after kind of a major surgery affecting their arm function, and just one group of patients just knew exactly what their therapy was gonna, involve, and the other group just didn't even know why they were referred to therapy. They just knew that they hurt, right? And you're absolutely right. Like, what advantage, I just want to kind of state the obvious right now, but what advantage do you see for more physical therapists being involved in the early surgical like plan, the treatment plan with surgeons?
Dr. Seagraves, that's a great question. So I see that the patient anxiety is down, right? And so they're more proactive in the entire process. Their adherence goes up a lot because they understand where they need to be, when 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 they need to be there, and also they can actually plan for what's about to happen in their life, right? So they can set up themselves for success. They can get if they have kids, they can set them up with another caregiver, let their work know. There's a lot of other things there that healing the stress, right? We know what stress does and the hormone response there too, and what that does to sleep and everything else, and our tissue healing times. So by having all of that met and tied up really nicely, the patient is more likely to get the ideal outcome. The reason why procedures performed, that operation is taking place. And a lot of times in the model that we have where like everyone is overutilized, right? There's not enough access to surgeons or providers or physical therapists. So what can we do to scale ourselves is, all right, we can inform the patient with, maybe they'll get a text message of like a video, right? And it's going to go through step by step by step of that physician or practitioner that they trust, right? And then that way they'll come in with better questions and more precise, nuanced questions for them, right? Because they know what to expect. And now it's all right. Now we ask questions because if a if a patient doesn't have any, that might be a flag, right? It's like, all right, do you know? And then ask them to repeat it back to you, like say like, yes, I have this covered, I have this covered, I have this. Great. All right. You're more likely to get that outcome. And that's exactly what we want that. They understand the possible complications and what we can do to limit it too, right? Or why physical therapy is involved, why they might need labs done prior to their surgery to limit their risk, right? Make sure their A1C is taken care of, make sure they're not vitamin D deficient. All of these factors can cascade, and we want to make sure that we have them in the right environment at the right time to perform the right procedure, because that's what healthcare is all about. It's making sure all those little things are taken care of to limit the downside.
You're absolutely right. There's a kind of now a push for using and leveraging that technology. And that's even really in your background, is that you and I both know there's not enough of us, right? To actually like uh, the biggest roadblock that we saw in women's health, where there were not enough therapists to address the amount of patients we saw, even in our oncology care, in our cancer clinic. We didn't have enough to see all the patients we were seeing after mastectomy or hysterectomy. We just didn't. And we know that the number one surgery that's performed, at least in this country, major surgery that results in an inpatient stay, is C-section. There's no way that there's enough of us. And so leveraging technology, that completely makes sense, is having a patient walk through a series of videos that could at least help them get prepared for the early recovery phase that they have the most control over. We try to get our patients just to be aware of just hemoglobin, right? That those levels could drop, but if they drop too drastically, this is what you want to be prepared for, symptom wise, and just be in communication with your surgeon about. And I think that leveraging technology, to me, is the only answer and solution to a problem where there's a too few therapists to actually roll out these protocols. And my question to you, I want to back up just a little bit, as I really do want to talk about technology in just a few moments. But you were talking about like the procedure itself, the surgery, and we were talking before this conversation about your experiences with observing surgery, right? And we bonded a little bit about that, because I started observing surgery as a PT student and continued through my residency. How important was that in helping you understand your role as a physical therapist in some of these early surgical protocols? How important was observing surgery for you?
Yeah, so when you actually see, so when everyone pictures surgery, they picture something like very precise and everything's like where it's supposed to be, which it is, except the patient, right? The patient is always changing there. So yes, you have these protocols in place, but patients come in different shapes and sizes. So seeing how the surgeon performs like knee and a hip and a knee, how he performed it changed. His angle and his positioning, the hardware also changed too. And the sales rep, it was a striker rep there. So he counted out 6 surgeries in I think less than 6 hours, and he went from room to room. But everyone had a role there, and so I first started witnessing like orthopedic surgeries and joint replacements, one of the most common ones, hips and knees, lower extremity ones. We have that down to a science now. We have that down, and that's why the OR times there are one of the, for the most part, it's less than an hour, depending on the how complicated that patient is. And they're moving you like, and you're under anesthesia and you're being like moved like a rag doll and opened up. And yeah, no wonder you hurt so much after the surgery. You were like basically beaten up with while you were asleep, in the nicest way possible. So yeah, no wonder you're having a lot of pain at night, and all that stuff. And knowing that, I don't know if patients want to know that. I don't tell them, but like knowing that, hey, like you had a saw there and this and that, like, yeah, it's going to take time. And we know how much time, around that. If everything is nice and you're very healthy and everything's around that 6 week mark, and we have a lot of the research part to actually like, get past that pain, and like what can we do for it, that's pharmacological and non, right? What like metabolically can we do? Because when you have the traumatic insult, and surgery is a acute traumatic insult to the tissue. That's what it is. You're repairing something, but you're creating trauma with it. And knowing that, knowing our background in that, it's like, okay, we're we have a lot of this pain neuroscience education now more than the previous generation. And we know about these tissue healing times, and we know that it takes about a year and a half to 2 years, depending on everything, to get that full healing cycle. How can we set that person up for success prior to that acute insult? What can we do to set up that tissue to make it better tissue before that surgical insult, so that the body is kind of primed to have the best possible healing response there, and that a lot of that's diet and behavioral stuff, and just moving and just making sure that they're getting strong and powerful there so that they can recover faster. So it's doing a little bit more work on the earlier side in order to get a better output later and a quicker output, ideally, so that a patient can go back to work, be a caregiver, be themselves, everything that they identify with.
Dr. Vapne, I'm curious about when you say tissue healing and tissue repair, the 2-year cycles and all of that, are you talking about, and this is going to sound like I am not a physical therapist asking this question, so you have to, bear with me because I really want people to understand, the basis of this question. But are you referring to different tissues of the body or just tissue in general? Like, depending on where you have a surgery, does the science change in terms of tissue healing and repair, if that makes sense? Like shoulder surgery versus knee replacement. Does the science change?
Yeah, so I got that information. I think it was from like the British Medical Journal, where they had this nice like infographic, or like this tissue, like a ligament is between this and this, right? Depending on the stage, and a tendon is this and this. Like articular cartilage goes up to this, and this, right? And so we have a lot of that research from, I think, orthopedics in general, of like different, like bone is like one of the fastest, right? A fracture heals pretty quickly, like depending on your age and your history, it could be like 3 weeks. And there's this magic number, 6 to 8 weeks, that's always in the mix in the research. And so you like see these gaps, but I think I saw that in order for the ACL in general, like, yes, you the you see typical 6 months of like therapy, and then if you wait every month that you go more and more and more, you decrease your risk by 50% when you hit the magical 10-month. If you do everything ideal and part of that protocol. But there's research out there where you're not really fully there, like neuromuscularly, until that 2-year mark after the surgery, right? And that's why you see a lot of our colleagues, our international colleagues, where they're doing these non-operative procedures in like New Zealand and Australia, where even if the person doesn't have an ACL, they might like regrow that ACL at like the 3 to 4 months, and then it's like, oh, okay, then we're not going to do surgery, right? They're like delaying that insult, because when you're doing surgery, you're actually creating a lot of trauma in that local tissue, in the muscle, skin around it, the connective tissue, the fascia. I know there's a whole big fascia crowd out there. The fascia as well, that keeps everything together there, and the nervous system, and how each person comes to terms with that response, right? How prepared they are mentally and physiologically, that matters too. So that's where I'm getting that information.
That completely makes sense to me. And to me, tissue type really drives our understanding of tissue recovery. But then I've come across different surgeons who are like, no, I don't really want my patients to start physical therapy until 6 weeks, or I don't want them to, be stressed too much. And I'm like, but they're still doing a lot. They're still, like, around the house. I mean, getting out of bed itself, I think that there was, a study that an occupational therapist on our team came across where, she was able to find the tension points of just of the act of getting out of bed on an abdominal wound, and how, that stressed the tissue there, and I'm just like, "Well, I never understood with our back surgery patients, we would see them within the first 24, 48 hours in the hospital, but then they wouldn't want those patients to be seen for another 6 weeks or so. So they went, 6 weeks on their own recovering after this major back surgery, but we only had those first 2 days in the hospital to, like, kind of get them on a recovery plan. It just didn't make sense to me. And so, from a tissue healing repair standpoint, is there any justification for surgeons to delay rehab for some patients after some surgeries versus others? Is there any science to support that?
Yeah. Depends on the surgeon. It always comes back to it depends, the magical phrase, and which drives me crazy a lot of times. So a lot of it is like trying to mitigate their own risk, right? It's CYA, from what I can tell a lot of times, but clinically, like they want to limit like infection risk, right? So if they feel like the closure isn't good enough, they want to limit infection risk. As much as possible, and like and there's two sides to that, like how much are we exposing them, like as a physical therapist, to an environment that could be can cause that. What are we doing? So a lot of times surgeons, they have their own experience, like some physical therapists that they probably worked with, maybe did too much or too little, and they just don't want to expose them to that because they had a previous bad apple right there, or bad experience there, that is influencing their future decisions. And you can't like not account for that. It's going to happen. There's going to be times um, where a patient gets underloaded or overloaded and then complains to their surgeon, and then the surgeon's going to have that in the back of their mind, even though they do probably like hundreds of procedures a year, thousands, right? And so they're going to have those highlights, right? This person says it's really good, and then these people say it's really bad. So they're going to try to limit uh, their risk there. But it's all about maybe having that communication with the clinician and be like, all right, this patient is more at risk. Maybe we delay it for two weeks and we give them some things at home, to try to do. But I feel like, especially with back surgeries, I feel like people are actually putting more strain on themselves by doing these things that they learn and then avoiding other positions that are actually producing less strains, right? So by putting themselves in this very guarded position, they're straining so much other stuff that it's actually to their detriment there, because they're moving less efficiently as a whole because they're guarding this one area, so they're straining everything else. So I don't know if you've seen that also. They're like, so they're straining their hips more, they're straining their shoulder more, they're straining everything else more because they're trying not to do the bending, lifting, twisting, which you're gonna have. Like you're walking to a house, going up a stair, down the stair, you're gonna have a little bit of bending, lifting, twisting. Getting into a car, you're gonna have that in some way, shape, or form. It's just we're creating so much fear around that, rather than like, okay, instead of doing it like super fast, like just ease into it, then maybe objectively timing it, and then seeing like, hey, like to get in and out of a car is taking you 25 seconds. Let's make a goal to cut that by 50% in 4 weeks, right? And just so that like it's like, okay. And so you're kind of gamifying it for them, creating this like leaderboard in their head where like, all right, I'm at 25 seconds, I'm going to slowly each week go down by like, a few seconds, and then it's like, oh, okay, like this isn't as bad. And that's just like a functional task there of getting down into the car. If it's a lower car, okay, you're gonna get a little bit more bending. and you're going to twist at some point, and just educating the patient that way. And I know um, there's complications that can happen, especially as like the bones are setting and there's recovery there, and you're going to want to use a bone stimulator for some patients that are a little bit more high risk. So there's a lot of factors there. It's about like how much can we educate the clinicians and also the patients, because they need to be an active part of it. If when they're a more active part in the whole process, it's just so much better for everyone involved.
I love that you're talking about this. This is probably what led me to finding a protocol to treat the patients that we were seeing that were coming back to the hospital after a cesarean section infection. And you're talking about transfers in and out of a car. I had the honor of interviewing Princess Castleberry. She's a TEDx speaker, Dr. Vapne, like international, like you know. A professional speaker, and she was talking about in the first week after her C-section, she was transferring in a Camaro, really low vehicle, and she unfortunately opened her wound and was back in the emergency room in the first week after giving birth. And in my time at working at a major hospital, it was a level 4 perinatal care facility, which is the equivalent of a level 1 trauma center. We saw 3 patients within a 3-month period, come back to the hospital for an average of 9 days of a readmission because of their cesarean wound opening. And I was just thinking even then, a protocol. I mean, what we're talking about essentially is that without a protocol, patients are stressing other parts of their body in attempt to protect what they think they should be protecting. They're actually stressing other parts of their body that are going to impact negatively, impact that wound anyway. And so around that time when we had those patients, we had those readmissions, physical therapy was now involved in their care. We weren't involved initially before they went home. I was searching for a protocol that could guide us on abdominal surgery recovery in the hospital. And Dan, I came across a hernia core surgery protocol that we use for C-section patients. And now I know you're involved in working with a surgeon on a abdominal surgery protocol specifically for his hernia patients. But I would love to talk about that. Like, what is that process like? Because I feel like if we're more involved in these protocols, we're going to see a lot less incidences of patients having negative outcomes. If they have something to follow, that's pretty uniform across their surgery. What's that process been like for you to be involved in creating a surgical protocol?
Uh, it was great, honestly, and we're creating a white paper around it, but uh, it started with hernia surgeries, and now it's going to like more general surgeries as well. Like if a person takes like any insult to the abdominal cavity, right? So you're tearing through the RA, the TA, some it's like anything there, and it's just like, what does that do to pressure regulation, right? It's like how a person breathes, um, because then you start seeing, and this is like basics physical therapy school. You need a stable base. Proximal stability leads to distal mobility, right? If you're not stable, how you're firing neuromuscularly changes, all right? If you're not creating stability, and people can check this with like a straight leg raise test, where uh, if you take a full breath, you lift up your leg, and like you're gonna get different effects possibly. But working with a visionary surgical team, practice that really wants to make sure that every step of the patient journey is controlled as much as possible. So, in order to deliver the best possible outcomes. And so, people don't realize this. Hospitals, um, they cost a lot of money, right? And so, as we go into the future and everyone talks about this value based care, readmissions like the ones that you noticed about these cesareans, like, that costs a lot of money for the insurance payer and the hospital. and and there's no value add there to the patient, right? It's like this is actually not a value add at all. We're now having, because we didn't do enough preemptively, now we have to spend a lot more money. So as these economic models in healthcare start changing, we're going to see that physical therapists are going to be valued a lot more, because we're actually the insurance for the hospital and the payer. Because if how we educate the patient in order to understand what's going on and things to look out for and things to work through is going to improve the overall cost of care. So what we have to do is make sure we're doing it right and having protocols that know, be like, all right, if this happens here, if this patient has a more higher complexity injury and we have guidelines for that, this is how we grade them up. And it might be slower, it might cost more on the front end, but it will save a lot more on the back end, versus a lower complexity person who's more fit, has better tissue quality, has less comorbidities, more educated, less anxious. They might have less complications. So we can actually speed them along, and their total overall cost of care is much lower. And so the better that we do triaging each person out to the protocol that works for them and making it as specific as possible, the better. I'm just going to make sure my chart is plugged in real quick.
Sure. You know what's interesting is that you y- you a protocol for me seems very like general. Like this is a general protocol, but we kind of forget. Like, of course, we can individualize it. Of course, I individualized a protocol when I was working with patients after shoulder replacement. So my question to you is like, how how did you what was the process of actually creating a protocol first for the hernia surgery population? Were you creating the actual, like, step by step, week by week activities that the person was gonna do? Was how much was the surgeon inputting, with that? What was that like?
Yeah, so the surgeon's team did a lot of work on the front end, talking about surgical methods and using the robotic surgery technique, and if it's an inguinal hernia versus an umbilical hernia, and so and the size of it. My side was more on the functional side, all right. And what I did is, all right, we focus on backwards, right? So what does the patient need? And we work backwards from there. All right, let's break it down. They need to lift, they need to carry, they need to get from place to place. So I worked backwards from there, and I was like, if these are the goals that we're typically going to see, very similar to a knee or hip surgery, right? It's like, all right, driving is one of their goals, right? Getting independence. Well, what's the biggest thing there? It's like I'm able to drive, like to the grocery store, back to my work, back, whatever it is, commuting, and then going upstairs, downstairs, and like their capacity for getting from place to place, dependent on the in environment. Hernia surgery, very similar. You work backwards and you break down the individual parts of it. And so in the very beginning, in the acute phase, it's like, all right, normalize breathing, right? Making sure that they can expand fully and go all the way down and contract that tissue, and making sure that they have neuromuscular control there, right? And so how do you measure that? And how do you progress it? Progress it maybe with some weight on the abdominal cavity, right? And make sure their breath can go the same amplitude there. Measuring, I don't know if you do this with your pelvic floor patients, but putting a blood pressure cuff underneath their
Mm,
lumbar spine and
correct, yes.
measuring to see the amplitude of millimeters of mercury there, right? And seeing how much control they have, what's their full amplitude there, what's the power like, how fast can they get to their maximal, how many times can they do it, the endurance of that, how much control they have with the eccentric contraction of that too when they're coming off of it. right? So grading that. And so like we do a lot of that in the beginning. And so that we gamify that process. You say this number's, your baseline's at a 40. When you push down, you're at like 100 millimeters of like mercury there. We're going to see how this changes week over week over week. And then progressing that to like, okay, we can do that in a supported environment. Let's do this in a harder position now when you have less tactile feedback. And so we position or this or that where you're getting more forces involved, gravity more involved, maybe a plantigrade position. And so it's all about using your clinical reasoning there, but you have these KPIs to look for, right? Making sure that a patient can uh, control breathing and then carry, and then for some reason everyone likes the 10 pounds. Don't lift more than 10 pounds, this and that, except when their kid weighs more than 10 pounds and they're going to lift up their kid. Like it's going to happen. And we have a lot of big kids these days. So I think the average birth weight went up. I think in the last like 5 to 7 years, like it's way higher. So you
Right.
have a lot of like 9 to 10 pound uh, babies coming out. So all right, try not to lift them after 4 to 5 weeks. That's not going to work because moms need to be moms. And so, how do we get from 10 pounds to 15 pounds to 20 pounds? And that is done over time and endurance and like making sure that you're assessing that week over week over week. And there's ways of making that 10 pounds feel a lot harder, right? You can add in BFR to the extremities, right? You can change the amplitude of movement where if you're carrying weight and then so instead of doing normal walking, you can do a larger amplitude. So start marching higher and higher with your legs so that your your time on one leg is more. And so you can start grading that up more and more, especially if you have people that are more rigid in those protocols. There's levers that as clinicians, we know how to pull because we do this so often and we recognize patterns and um, we know how to progress people really, really well.
How early did you start with your patients? Specifically after hernia repair, how early did physical therapy start in your protocol?
Before they had the procedure. So, so before they had it, because I wanted, and we thought it was very important that they meet where they're going, right? They meet the clinician educates them like, this is what you may feel, this is my, like, and so that they feel comfortable. And then depending on their complexity, I might see them a lot more often just to make sure that like my job is to make that procedure as easy as possible for the patient, but also for the surgeon, right? So if I can do all the little things, that makes the surgeon more efficient, where he can go in, go out, and he has a happy patient that's informed there. Amazing. I'm such a value to him. I'm integrated as a partner to his entire practice, and that's how we need to think. Is like we provide so much value. How are we communicating that to our peers, right? It's very common with pain management and orthos, and there's a lot of like relationships there. How are we communicating that to cardiothoracic surgeons, right?
Yeah.
I'm working with a cardiothoracic surgeon as well, and a lot of times he's doing rib resections and this and that, and it's like, okay, like, how, are is the patient aerobically like in a good place or anaerobically in a good place? What does their breathing look like? Are we measuring it with a spirometer, right? And so can we track that before the surgery and then get back to it after the surgery, right? If we have a good baseline prior to the insult, which is the surgery, then we can get closer to that mark, right? And so it's important for us to meet the patient before it, and then afterwards we can assess, all right, we're basically 40% of where we were versus not knowing what success looks like, because we don't have a baseline.
You're absolutely right. I think, for planned surgeries, Dan, this makes complete sense, and it's something that our clinic, just did not do really well, is actually meet those patients who were planning a mastectomy, who were planning a hysterectomy, meet them before they actually went through the procedure, because we worked so hard on the back end just to try to see if, we can convince the surgeons to refer them at 2 weeks post-op, and even that felt like too late, you know? I mean, it felt like they were already trying to navigate all these activities for 2 whole weeks before we even saw them after surgery. And so after surgery, how soon is your team involved? Or at least when is the patient given that protocol? Like, what are they doing, graded activity-wise, and then how soon after
Yeah.
surgery?
Yeah. So we, before the procedure, we go through like the safe exercises to like work on, and a lot of it is going to be, they're going to feel pain, right? So we work on the deep breathing. They work on like, and these are things that they feel comfortable because we met with them once or like 4 times prior to surgery, maybe even more depending on their complexity. And like we got them ready for like their things that they're going to do after surgery. So feeling comfortable with just breathing, feeling comfortable with like carrying lightweight, how to do it, different strategies, right? Carrying maybe closer to your center of gravity and your base versus away. Making them aware of like what a contraction feels like and how their body should respond. Uh, Showing them how to get in and out of their car, right? So like, all right, setting it up so that we're decreasing as much strain as possible where we can if we want to. Um, Putting on your socks and shoes, right? How are you going to do that now when you're healthy? And then like, what do you think that's going to look like after this, right? Maybe having ordering with them aids so that it's easier for them, setting up their environment for success, for that complication risk to go down. And so this idea already exists. We participate in HSS Rehab network up here, and before their hips and knee surgeries, they have a physical therapist evaluate the patients prior and like show them how to do these things, and they charge that like hospital eval PT visit for that. So um, this isn't novel. It's just not scaled enough, and it's not common practice yet. And I feel like it's a huge value for the patient to have these educational visits and to show them and maybe record a video on their phone so that they have some visual aid to go back to. That is huge, and that is so much more valuable than that typical plan of care where you don't know what to expect. There's so many questions, you have so much anxiety, you feel like, excuse my language, but crap after the surgery, and you're just like, oh, when is this going to end? And you're taking these medications, maybe a painkiller, which affects tissue healing times too, and how you feel, and then you can't drive. Maybe a nerve block, maybe a high NSAID, which also impacts tissue healing as well. So all these pharmacological things, because it's easy to do that and doesn't require a lot of education for the patient. But what about the other strategies that have less of those pharmacological downsides, right?
Yeah. I wanna ask you a consulting call, 'cause now I'm kind of just thinking like, okay, if we're to scale this, and we're to scale this, especially like in my field of women's health, how do we go about this? And I wanna give you a very specific example. So we talked a lot about like kind of the surgeries that I've seen. Uh, and also that we've both seen in orthopedics, right? You actually have gone even beyond what I talk to most therapists about. You've actually seen surgeries involving the temporomandibular joint and actually been able to see what tissue was cut to guide you on the therapy that you would do with that person, manual therapy or any of the interventions that you would do. And What I want to ask you specifically is that there was a group of patients I started working with the surgeon on after cesarean hysterectomy. You can kind of imagine like what that involved, but it's
Mhm.
about a 4-hour procedure. One of our surgeons, who's a physician champion for us, has seen procedures run as long as 13 hours. And with that procedure, we would see them in the hospital, but Dr. Vapne, they would go out into the void. We didn't have any kind of plan to follow up with those patients. I mean, this is a major surgery, and they had a baby to care for. And what I thought about even then was, well, how about creating a protocol so that across the board, if they're anywhere, if they're traveling far to get this procedure, because not a lot of surgeons do it, they could go, take that protocol back to a clinic, someone who's at least familiar with abdominal surgery recovery, and they could get at least someone who could guide them through their recovery. But that's kind of where we just stopped. Like I just became stuck in the how to start, what is the evidence that I have to do? What's the data I have to gather? Do I have to run studies to see if this protocol versus this protocol? I started getting into the weeds and just getting too complicated and probably started overthinking it. So if you were to talk to someone like me, which is probably a lot of our audience, Dr. Vapne, how do we start? How do we just start? We recognize these patients are not given the proper care and instructions of recovering properly after their surgery. Where do we start with helping them?
Yeah, yeah. So we start with relationships, right? We have to create relationships with our peers. In the fee for service model that we live in, where time is money, like literally money, and so you don't have time for that. Is like, how are you going to follow up with sending that referral out to their community provider, right? So they drove 40 minutes for the surgery, maybe 2 hours for the surgery. They're not going to spend that time coming to physical therapy each week. Whereas there's a lot of people that they get there, get back. It's a big time drag. It's very expensive. How are you going to create self? And for me, it's like you have to take a video of yourself, and that it's like 5 to 10 minutes that you can actually send with your referral to that community provider that they're going to see for rehab afterwards, and say like, hey, I attached this PDF. This is my email. You can reach me at Dr. Rebecca Seagraves at blah 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 .edu. I've attached this PDF. If you have any questions with it, you can email me. Here's my contact information. This is kind of what stage one looks like, two, three. And basically you've scaled yourself so you don't have to have the same conversation over and over again for every patient that lives outside of that 5 to 10 minute radius of driving, right? So you've just consolidated your knowledge and applied it. So a skilled clinician that's a PTOT that feels comfortable within that pelvic health can do really well. So you have a higher level version of that, and then you have a version of that for each patient. Like, hey, you just saw me, and so uh, I just wanted to make sure that you feel comfortable. Here's a review video of everything that we went over that first day, right? So don't forget this, this is this, and that visual aid that they can go back to. Not only is that an educational video for the patient or provider, but you've just built trust. You've just built a relationship there asynchronously, which is how a lot of Gen Z likes to work, asynchronously, right? And so they can always go back to it, and they can follow up, and eventually you can triage that too. So we know there's not enough of us, and so how are we going to take what's up here and what we've learned through trial and error and time and through our own mistakes too, because that's where the most learnings happen. And how do we not allow other people to make those same learnings? How can we cut down that curve? Is like, we create these little video segments, and we make that a part of the patient journey and the clinician journey and the relationship piece, because those follow-ups are timely. And so if we can shrink it down, and if we can accelerate it, and they can listen to you at like 1.2 speed. I'm from the South, so I speak very, very, like a little longer. So I would rather people speed me up a bit because I'm a little bit more energetic when you speed me up a bit. Or you can be like Elon Musk and speed me up like 5 times. It's fine.
Oh, that's great. This is such gold. I can't thank you enough, Dr. Vapne. And I know you teach students. So my mind went like 100 miles an hour just now. And I was just thinking man, how about if we like actually instructed students on making these protocols while they're in school, while they're learning about tissue healing and repair, while they're learning about the anatomy and physiology of the tissue that's actually being impacted with these major surgeries. Like you said, we're beating people up while they're asleep, right? We're sawing through bones. We're really creating a lot of trauma and damage, and then we're having them heal on the back end. And if we created the protocols first with the base knowledge that we know of what activities would be safe to do at each stage, then we present that information to a surgeon, and and then on the back end, like what you're doing a white paper on the back end of this hernia surgical protocol that you've developed with the general surgeon. Is that right?
Yeah, yeah. So he has a group of, I think, 7 surgeons, and I think it's going to be more. It's Dr. Haller at Long Island Surgery, and so we're in Nassau County, and we're affiliated with Catholic Health there, and so we're trying to figure out, okay, how can we best improve um, that patient journey with not just hernias. So we're starting with hernias, but then general surgeries, and then how can the patient access us, right? Does it require a home health visit? And then you'll have a virtual visit to create access with like a triaging one. And then they'll go into the clinic for a more robust plan of care where they're loaded and they're assessed more thoroughly, where you're in a closed environment trying to stress them enough where they can handle anything life throws at them. And I think that making sure that you're accessible, whether it's like those videos with education or a telehealth visit or a home care therapist that feels very comfortable setting up the patient's environment to be as supportive as possible, and then getting the patient to get to the clinic, that is going to improve the whole experience so that patients will get the best outcome, diminish readmission rate, and save the system as a whole so much. And that goes down to every stakeholder involved: the hospital, the payer, the patient, the clinicians. It's just going to be a more robust experience.
Yeah, I totally agree. Is there anything that you want, just rehab therapists in general, just the take home message for this to be, when developing rehab surgical protocols, my biggest take home from you, Dr. Vapney, is develop the relationships first. To develop the relationships first with the surgeons, but then also with key stakeholders, providers in that person's community. Because, like you said, I mean, patients are sometimes driving 2 hours to get a surgery, but then going back, and who do you want them to go back to? Is it videos that you've created that they can kind of see on the back end? But then who's their touch points in those communities? And if they have your protocol, then you've now expanded and scaled yourself. I mean, you're using technology to me the way that we really need to be using it like right now. You're already so much ahead of the field. What's your kind of final messages to clinicians now who just want to be right there where you are?
Yeah, yeah. I would definitely start with creating relationships with patients, right? So you don't know, because this all started because one of my patients had a relative that was a surgeon, and then it got other people talking, and then they understood your value, and they wanted other people to have that quality experience, and so you can only see so many people. So how do you create that as a clinic? So my practice, we grew to 7 physical therapists and 1 occupational therapist right now, and because of our relationships in our community. And I think the research says that people are more likely to go to physical therapy if it's accessible. All right, what is accessible for physical therapy? It's like 5 minutes, no more than a 10-minute drive away. That is, you figure out how many lives that is basically your target audience. And then if you figure out a way, all right, if I can create a way where they don't need to come in as often, the frequency of their plan of care doesn't need to be as robust because they understand everything, the education's there. We have these visual aids. And so when they come here, we're just assessing where they were the previous week, or whether it's having those KPIs of the blood pressure or the spirometry or anything else to see, okay, they can actually do what they need to do. We have to make sure that it's clear, and so that way they know that the next time they come in, they have to hit that mark so that they can get to the next phase. And if all of that is very, very clear, I don't see how we can't create a healthier community across the entire nation, right? So each community becomes healthier and healthier.
Oh, that's fantastic. This is awesome. This has been, probably one of the best consulting calls that I could have even, coordinated with you. I can't thank you enough. I really can't.
Dr. Seagraves, it was a pleasure. I'm sure we'll talk soon.
Agreed. Thank you so much, Dan.
Thank you.
Wow. Thank you so much, really, just for everything, that you gave. I think honestly,